Hello everyone, this is Fire Chief Paul Dowd with Albuquerque Fire Rescue. This podcast is designed to bring you helpful training and best practices and some additional resources that you can access from anywhere. So thank you for joining us and enjoy today's episode.
Farm 2, Engine 11, Rescue 11. Engine 11, Rescue 11, respond out to USS Bullhead Park. It's going to be at 1606 San Pedro Drive Southeast, cross street of the U.S. Veterans Hospital Loop. Responding out to a 6-month-old female. Unconscious, she is breathing. She was hit in the head with a baseball. It's going to be a 30 Delta 3 for Engine 11, Rescue 11. It's going to be USS Bullhead Park, Field 3, 30 Delta 3.
This is the AFR podcast. Today we're talking about pediatric trauma, and once again I have Captain Kevin Ferando. Hey Kevin, thanks for coming on again.
Thanks for having me, Andrew.
And we ran a little bit long. We tried to do all-inclusive trauma, but there was just so much stuff going on with those 2 patients that we had that we have to make a whole separate pediatric trauma podcast. Kevin, what's different about kids and adults?
So I think the first thing to recognize is that they're not little adults. They're their own separate patient that you're going to have that's going to present a lot different than adults. So some of the things that I think we should focus on just obviously is going to be their anatomy. The obvious thing is they have a larger skull, larger head, which makes up a big part of their body. So they may not have that balance because they're kind of top heavy and not going to be able to have the same balance. They don't have the same coordination, same muscle growth as us as adults. They do have a lot less fat. Their bones are more elastic. Their soft tissues their connective tissue is more elastic. It's more pliable. As far as their organs go, they're more tightly condensed, more tightly packed. So that means they're going to be a lot closer to the surface and more susceptible to trauma. That's one thing that with these softer bones too, and organs that are in this tightly packed space. So those impacts, those falls could definitely cause more internal injury, more internal trauma than it would to an adult.
So how do we treat these kids? First, do you have any kids?
I do have 3.
Okay, cool. Yeah, I got 3 kids too, and I feel like that's kind of the way that I've learned the most about kids is just having them get hurt, my own kids get hurt. So I feel like that helps me take care of them a little bit better. But imagine that we have some 23-year-old people in our department that, don't like holding kids or touching kids. What should we let them know about the best way to take care of kids?
Well, I think that you have to be child friendly. You really have to just be able to put yourself in a situation that's less threatening to the child. You can always use the parent. That's going to be one of your best assets on these scenes, depending on the age of the child, depending on the level of mentation of the child. If it's maybe not the most critical, if it's just rolled off the couch and they're kind of crying, they're inconsolable, it's going to be, mom, dad, maybe the best person to hold that child while you try to perform that primary assessment, that secondary survey, and, before you start really dictating what kind of treatment you're going to get. If it's maybe a little bit older, you start getting these different age groups, and some of these kids respond to, strangers differently. But the best is try to get to their level.
Okay, so when you say get to their level, that's kind of like actually crouching down. You don't want to be towering over these kids. And then if there's a person that seems like they have a better relationship, maybe there's somebody with kids on the crew that knows more about it, have them be the one talking to the kid,
Absolutely. If you're more comfortable with, being around children and being able to kind of relate to them, use that to your strong point.
Okay. So again, we're talking about pediatric trauma today, and trauma, once you get past 6 months old, trauma is the leading cause of death in kids. And with that, head injuries specifically are a big killer. So head injuries are going to account for between 70 and 80% of all pediatric deaths. So we're going to start there. I know we spent a lot of time talking about head injuries on the last podcast, but we'll do it a little bit more since it's such a problem with these pediatric patients. All right, we'll go into, again, most severe kind of head injuries first. We'll talk about epidural hematoma. This one, good mechanism would be like a blow to the side of the head. So right around the ear, kind of that soft spot by the ear, you should be suspicious of a epidural hematoma. That's going to be that arterial bleed, and they're going to get worse very quickly. And that's going to be different from your subdural hematoma. So remember, subdural hematoma, that's going to be venous bleeding. Example for kids would be maybe shaken baby syndrome. So if that brain is shaking around, the skull, the bottom of the skull has a lot of stuff for the brain to rub against, and it can cause a venous bleeding, which is going to be that subdural hematoma. Some other things that you learn about with head injuries in the textbook would be like a basilar skull fracture, where you're going to have raccoon eyes or battle signs. But Kevin, what do we need to take away from some of those different signs?
Those are going to be your late indicators of a trauma, and a lot of times those are going to be related to your child abuse cases.
Okay.
So if you start seeing kids who maybe, do present with these raccoon eyes or this bruising, you start going down that, was this a child abuse case? You need to expose these kids. You need to get a good assessment. And like I said, those are more of a late sign. So this is something that's happened, probably prior to 24 hours and then some.
Okay, so we'll come back to child abuse in just a second. Let's wrap up with real quick on the different head injuries. So those are some of the serious things we could go on. I guess a little bit one step down from that would be something like a concussion, maybe for a teenage age group. Do you have any experience with those?
Yeah, so I've worked in the Peds ER at UNM for a while, and it's been several years ago, but we see a lot of kids come in. Your contact sports, you have a higher likelihood of, having these kids who will have a concussion, mild, minor, major. We'll talk a little bit more later on about maybe recognizing some of these signs. But, at its simplest, it's a bruised brain. And, they're going to have altered mentation. And so kind of the things we're looking for with these head traumas is going to be just, how they're presenting. Are they nauseated? Are they having any vomiting? Are they just not acting appropriate? Obviously, if they're knocked out, that's going to obviously give you a higher indication that this is a serious head injury, and that's going to need 100% transport to the hospital and evaluation. A lot of times, the minor ones, or if child rolls off the couch, they're crying, they're behaving like a normal child who, suffered maybe a fall. That might not necessarily be that head injury. That might not be that concussion. So you go back to, as a parent or as a provider, look at the child. Is he behaving normal? Is there any indications that that's not presenting right? Would this be something that's needing to get evaluated and further looked at the ED?
Yeah, I'm glad that you're here. Actually, you mentioned you work in the Ped ER. I think it's helpful to understand what's going to take place at the hospital. So we went through all the serious head injuries, and those definitely need to be transported right away. I've been on dozens of calls of little kid running around on the couch, fell off, started crying right away, didn't get knocked out, acting fine now. We show up and the kid looks completely fine. So we're never going to tell somebody that they shouldn't go to the hospital, but we can educate our patients prior to them going in. So working in that Peds ER, what is going to happen? What treatment are they going to get for that situation, just to be able to educate our patients?
Well, for the kid who just falls off the couch and, parents are concerned that they did hit their head, you're going to just do a lot of just observation, not necessarily any x-rays or CT scans. If you have a 3-4-year-old who does fall off and they are presenting normal, but it was enough of an impact that the parents thought, let's get this kid looked at, completely appropriate. However, when you have a child that's going to have to be required to sit still, be cocooned in a Velcro blanket and then put into the CT scanner, that's pretty traumatizing. And a lot of times you're not going to have a child that's just going to sit still. So they're going to just watch those kids for a while, see how they're doing. And if there's indications that they need to get further evaluated, then, the doctors at that point are definitely going to make their decisions. Once you get to the ER, though, physicians are going to do a head-to-toe evaluation, but a lot of it just really revolves around just observation.
Yeah, and the doctors don't like to radiate those kids, so that would be like a X-ray or a CT just arbitrarily. So they're gonna want to have some indications that it's necessary. In Dr. Pruitt's lecture on head trauma, she mentioned PCARN, and again, it's just something that physicians use in the hospital to decide if they're going to do a CT on this kid's head. So some reasons that they would do it: if the kid's got altered mental status, then that's going to be a reason to do it. If they're vomiting after they fall and hit their head, or if they lost consciousness at some point, those again would all play into their decision on giving that head CT. But if not, if they fall off the couch, no loss of consciousness, no vomiting, if they're old enough to say that they have a headache, if they don't have a headache, then all of these things, they're not going to get a CT most likely at the ER. So I think a little bit of education to the parents. That's what they're looking for, right? They call because they're scared and their kid's crying. So I think if we're able to educate them a little bit on the process and what's going to happen when they go into the hospital, that'll be helpful when they're trying to decide whether they want transport or to transport their kid by themselves. So that's important for us to know. And it's good that you worked in that ER, Kevin. Do you have any last thoughts on that, again, about the treatment that they're going to get going in?
Not really. One thing is if the child's crying, as us as providers, we walk into some of these houses, and if your child is upset, that's actually a good thing. We don't want to see this child who's just laying there, who's not behaving normally, not behaving age appropriate. Those are the ones that give us concern. If a child's crying, natural response to pain or fear, and that's usually a good sign. Yeah.
Okay. So now we want to take a moment to cover child abuse. I haven't personally been on a ton of these calls. I've been on a couple where the parents have some really weird story, that just doesn't make any sense in my mind. I'm like, why would that have happened? But since you worked in that pediatric ER, what examples have you seen or of some abuse signs?
Unfortunately, a lot of the ones that we did see they were pretty severe. You're gonna, I think, look at burns. You're going to look at bruising. These kids will have a tendency to even bite their lips, depending on their age. You'll see like bite marks on their bottom lip. So that's a grimacing move. So if you see weird things about their lips or even their mouth, even this piece of skin that attaches from the lip to the tongue, the lip to the teeth can get pulled. So if there's tearing on that, these are kind of indications that there might have been some child abuse issues going on. So we kind of talked about exposing these kids. Just do a good primary survey. I don't want everyone to be suspicious that every pediatric call is a child abuse, but do a good, thorough head to toe. Look for signs of, burns, the bite marks on their lips, any kind of weird bruising, things that just don't fit the norm. Maybe even how he behaves around providers. That's one thing that I remember when kids who did suffer from child abuse came into the ED. A lot of times they weren't scared of providers, and it was kind of interesting that my kids wouldn't look at a stranger without complete terror. A lot of these kids that would come in, they'll go to anybody. It's just a different behavior. I can't really describe it, but they just didn't seem like they had that same fear of people that a lot of kids normally have at that age.
So maybe it's a little bit different. I guess in the beginning we're talking about using the parents as the comfort for the kid, but maybe in this situation would the kid be more comfortable with you being the one to hold on to it, or is that what it sounds like?
I think it's just you'd have to really gauge each situation differently. Some of these parents are just going to hand the kids off. I don't know if, try to read the parents, try to read the child. It goes back to just good assessment, good primary survey, obtain that history. You're kind of interviewing everybody in that area, in that room, in that home. So, and there's a lot of indicators. Some of the ones I did see come through the PEDS ED were, it was pretty severe traumas, a lot of breaks. You'd see these fractures that were in several stages of the healing process. So a lot of bruising, and just be very observant to that.
All right, let's move on to chest trauma. So again, we had a trauma podcast recently, and a lot of this stuff, they're kids, but they still have a chest, they still have an abdomen. So we're going to run through real quick, say chest trauma, and just talk about the differences again in chest trauma to kids versus adults.
Absolutely. So like we said earlier, these kids have more tightly packed organs in both their abdominal area and their thoracic area. So that means that those structures are going to be closer to the surface, more susceptible to injury. And, when these kids have suffered these impacts, whether it's a bicycle wreck or a fall or a motor vehicle accident, it's going to give you an idea that, hey, this is a potential for that trauma. They're not going to present the same as adults. They can they can compensate a lot longer than us. They can keep their vitals at a normal rate with a 25 to 40% loss of blood volume. It's going to be one of these signs where they look great until they don't look great, and then at that point we're already behind the curve. As far as the chest trauma goes, it's completely acceptable to dart these kids if they meet that tension pneumophysiology, but make sure that they are going down that route, not just let's dart these kids.
We want to have hypoxia, we want to have absent lung sounds on one side if you can hear it. And when they start becoming hypotensive, that's, again, it's hard to say whether it's from the bleeding or from the tension pneumo, but once you start getting that hypotension, that's when that is pushing into the tension pneumo category.
Correct, and that's when then now we're going to start making sure that our patient's going to match our treatment. If you look at the guideline, there is a reference for pediatric needle decompression, so it's age-based, and it's going to be 0 to 5 is an 18 gauge, 5 to 12 is a 16 gauge, and then over 12 is a 14 gauge. So.
Yeah, there's a lot of like different numbers on like what isn't a kid anymore, and it kind of depends, but 12 in our department, kind of the cutoff for like intubations and crikes is going to be 13 and up, and so that you're going to treat 12 as a pediatric. So it kind of changes depending on what you're talking about specifically, but there's going to be different ages. And if you get to this needle decompression, anybody over 12 is going to be a 14 gauge. And
their anatomy is different, so they are using their diaphragm a lot more to actually breathe, get those ventilations in and out. So, you might not see the same indicators as you would in an adult.
One other thing that can happen in kids is still going to be classified as a trauma, like this commotio cordis. So like a baseball or a blow to the chest, if it happens at just the right time, it can send this kid into VFib. But you don't want to treat this as a trauma arrest. You want to treat this as a medical arrest. So get the pads on. If it's appropriate to defibrillate, then go ahead and defibrillate. That's kind of the one caveat. Although it's a trauma, you want to treat this as a medical code.
Absolutely.
Let's move down to the abdomen again. Same things that we talked about. I think the last one we had an evisceration, but just talk about the general differences again between kids and adults.
It still goes back to their anatomy. It's just organs are closer, more densely packed. One of the common accidents what we see is those elementary school age kids, bicycle wreck and handlebar into the abdomen. So there's a lot of organs there that are very close to the surface that they can definitely injure, rupture. The spleen is right there, and it's going to be very susceptible to rupture, tear, and that can cause you bleeding out very quickly. So if they have that pain, that abdominal pain, if they're having a hard time getting over that pain or that impact, start really thinking high index of suspicion there might be some internal trauma.
Okay, so I mentioned that we've both got kids. Not everybody has kids, but I'm sure most people were a kid at one point.
I hope so.
If that's safe to say. So just think back to some of the stuff that you did when you were a kid. And I think, Kevin, you were telling me that you had a splenic injury.
I had several breaks and, fractures growing up, but I was probably 16 years old. Just in the middle of a football game, I took a helmet to the abdomen and suffered a very partial spleen rupture or tear. It was interesting because, it felt like just you got the wind knocked out of you. Nothing major, really couldn't stand up like I thought, and had this just a diffused abdominal pain. One of the later signs, though, that evening, I started getting really bad left shoulder pain, which is pretty common with, I guess, spleen injuries because there's a lot of
sign, huh?
Yeah, a lot of nerves. So, mom was like, "Yep, we're going to the ER." Actually, did do some CTs. Saw that there was a small tear. They didn't remove my spleen. A lot of bed rest though, about 3 weeks, and then back to normal. But what's interesting is that pain in my left shoulder lasted it was intermittent for probably a year. Not debilitating, but just you knew it was there. Very strange, even after everything was completely healed up. So
that's crazy.
I was fortunate that they didn't have to remove my spleen, but
I always thought that was just another doctor that wanted to have something named after him, but it turns out it's a real thing.
Yeah,
huh?
no, it really did. Yeah, it was pretty painful. So,
and apparently that's Kurzsign. It can be for referred pain to the shoulder from the spleen. Also the liver, it's still called the same thing. So, but the liver is going to be over the right side. So just look out for that if you happen to hear it. All right, so we're moving down from the abdomen to the pelvis. So again, pelvis is going to be about similar to what we talked about in the last podcast. You want to check for the pelvic stability. If it's unstable, you want to be able to splint that pelvis to try to stop the bleeding in there. Now, if the kid doesn't fit our pelvic splint, then just remember that you can use something like a sheet or like a blanket from 5.5, and you just want to put some pressure on that pelvis to keep it closed and try to stop the bleeding.
Yeah, very vascular in the pelvis region, and just minimize the movements in that area.
Okay, so everything we talked about prior to this point has been pretty bad injuries. Now, I think most common, this is what we're going to see most likely day to day responding out to calls. So we got more of like an isolated extremity injury. What are the takeaways we need to remember about these injuries, Kevin?
I think the biggest thing is that, these, like you just said, Andrew, this is going to be our probably our number one thing. You go to that kid who fell off his bike, he fell off a skateboard, he's got, whether it's an obvious deformity to his arm from a, fracture, or if there's just pain to that area, we want to make sure that we're treating their pain. I think we have gotten a lot better at that, but I think it's scary to give these kids, pain medications, but that's what we really need to do. That's going to be probably our number one priority, is just let's get that pain addressed. And, as we're working on whether we're splinting or whether we're, how we're treating it, if there's no major bleeds or anything like that, it's a very simple, just a broken arm or extremity fracture. Let's make sure we take away that pain as best we can.
Yeah, it can be traumatizing. I still remember I jumped off a swing when I was 8, and I reached out, my arm kind of hyperextended. I broke my arm, and my mom was a nurse, so she didn't care at all about my pain. She just took me in POV to the hospital. Then we showed up, and my arm still hurt, but nobody cared still. And they brought me to the X-ray, and were moving my arm around. I was trying to kind of like guard my arm and hold it in a bent position. They were like straightening it out. They're like, hold still, because we can't get this X-ray. And not once did anybody consider give me some pain meds. So
I had a very similar arm break story. My mom did not give a whole lot of sympathy for my broken arm as well. Drove me to the ER and ended up getting 2 plates in my arm because they couldn't set it. It was broken so badly. But they actually did give me pain medication, so maybe I was one up on you on that one.
There you go, yeah. See, that that city's hospital should be more proud than Cleveland, I guess.
Yeah.
One other thing when it comes to these injuries with kids is believe the kids. If you got a kid just going on and on about an injury, a lot of times parents kind of like to dismiss it and not believe them. But, I think both of our daughters have had broken arms that we did not believe them.
Correct, yeah. I'll tell you my daughter's story. So, yeah, she suffered a fall from one of the bounce houses. My arm hurts. You're looking at it. No swelling, no bruising, complete range of motion. It hurts. And you're like, well, but, let's just keep an eye on it. Here's some ice. 24 hours later, and it's still bothering me. All right, let's go to urgent care. They x-ray it, and it's a broken arm. So, oops.
Right. It took us a while to bring my daughter in, and so we finally brought her in, got an x-ray, and the x-ray was negative, and she kind of just was whining about it for another 3 weeks. So we brought her to an urgent care. They didn't take an x-ray because they looked and were like, she got an x-ray. It was negative, so we'll just give her this splint. And she kept complaining about it. She had like an orthopedic follow-up, and then finally, a month or 6 weeks after her fracture, they're like, oh yeah, it turns out it's broken, but it's already healed, so we don't have to worry about putting a cast on it or anything.
Yeah, that's, it can definitely fool you. They don't present the same way. We talked about their bones are more flexible. My daughter's the same thing. It was, there was never any deformity. It was, the green stick break, very minor. You could hardly even see it on an x-ray, but it was still enough to where they splinted it for a few weeks.
All right. So the point of this, again, is to treat the pain. So what are our options, Kevin, for treating that pain, even at the basic level?
So basic meds, you're going to be able to go down the Motrin route. We can do 10 milligrams per kilogram. We also carry Tylenol, so 15 milligrams per kilogram. These are great choices.
Yeah, these are getting into. So Motrin is going to be for the basics, and then as we get into intermediate and paramedics, and we can start moving down.
We can use Toradol is another option, so 1 milligram per kilogram IM, and we can do 0.5 milligrams kilogram IV or IM. So when we start looking at our narcotics, it's going to be fentanyl is going to be our choice, and your dose is going to be 0.5 and to 1 milligram or microgram per kilogram. So our routes of administration for fentanyl, we can do it IN, so intranasal, IV, IM, and don't discount giving it IN. It's a great way. You have that 8-year-old whose last thing he's going to want is to be stuck with a needle And so, you give these kids IN based on their dose, and it might just be enough to take the edge off to where you're still going to get a line started. With all that being said, look at the patient, try to gauge where their pain is, and it might be difficult on a 3 or 4 year old. Maybe a 7 or 8 year old could really vocalize how bad it hurts. Hey, is this the worst pain you think you've ever had? Try to really understand it. It might be a little bit more difficult with a child, and then treat the pain appropriately. One of the other things is vitals are vital. Let's try to get those baseline sets of vitals before and after any medication administration. So, and then just constant monitoring.
Yeah, I'm glad you bring up the nasal route, because I think just for the speed of actually, treating that pain as soon as you can, this person is suffering. You want to get them out of that suffering state, as soon as possible. And in my opinion, it's a lot easier to just get the fentanyl on board nasal. And that way, once you do follow up with an IV, say later on, they're already feeling better at that point. So for me, it's real quick to, no matter what the age of the patient, to give the nasal route. One thing you have to remember with the fentanyl is we want to get them on Capno afterwards, because that can affect the respiratory drive. So
absolutely. It goes back to just monitoring the vitals. One thing I wanted to add to extremity injuries, a lot of times we want to be quick to get these kids in a SAM splint, or, maybe sling it. And what I have found is, sometimes this causes more discomfort to those kids. If they find themselves where they're pretty good in the position of comfort, and they're able to hold that arm where they're comfortable and they're not having any extra pain, and we feel that we can move them without it being jostled or causing them more discomfort, I just have them self-splint, and that tends to work a lot better than us actually trying to manipulate the arm, set it in a SAM splint, wrap it with Curlex, sling it. I've seen that where the kid's doing good until we try to actually make it better. So they can give them more sedation meds at the ER. They can do a little bit better job of treating that pain and getting that arm ready for X-ray.
One note, also, I know we don't carry ketamine, but just remember it's an option that 5.5 has. That's supposed to be pretty effective on kids. Last topic we're going to cover in this podcast is going to be burns. So again, Kevin, the pediatric anatomy expert, what's going to be different about these kids, and what do we need to know about burns in them?
So the one glaring thing is their heads are bigger. And so instead of it being worth 9, it's worth 18. Where they take the numbers from is the legs are now down to 13.5 for each leg. So our palm method is going to be pretty effective, and it's their palm. So, and that counts for 1%?
Okay, yeah. So depending on how big it is, you can do those different methods that estimate the body surface area of the burn. You are going to want to do that. Then some other treatment you're going to do is where they have the burn, you're going to want to cover that with like a burn sheet that's not going to, Curlex is going to get kind of stuck. And then when you go to take that Curlex off, it's going to rip some skin off. So you want to have like a burn sheet kind of material or a non-adhesive dressing on there. Treat the pain. Again, we just talked about that. You want to give a fluid. So if you look in our guidelines, it talks about fluid resuscitation in burn patients, and it breaks it down into, 0 to 5, you can give 120 cc's of fluid, 5 to 14, 250 cc's, and then over 14, you give 500 cc's. So, we used to have like the Parkland formula to calculate and all that, but our guidelines kind of simplify it for us, and just it's age-based. So if you have a burn, just go to our guideline, reference the age. The same can be said for cyanokit. So if you have somebody with a smoke inhalation, altered mental status, and maybe they're starting to have hypotension after that, then you want to consider cyanokit, and just know that in our guidelines, it breaks it down by age, whether you're going to give, an adult, you're going to give the full bottle, but pediatrics, you can give 1/8 of a bottle, 1/4 of a bottle, half a bottle. So again, just check the guidelines. Any other takeaways, Kevin, that we need to remember about burns in kids?
Just to touch on the cyanokit, if they have any indications of that smoke inhalation, hopefully as a provider, they'll be aware of that. We're going to put Capno, we're going to start oxygenation, watching that airway, making sure that it's not going to close up. As far as administering a cyanokit, it's going to be 7/8 will have it on their trucks, squads have it, or squad 1 and squad 3. So we're just going to take it, and like you said, we're just going to go right off the age base and administer it per that.
Okay, and then when it comes to airway for the burns, remember, we're not criking or intubating anybody under the age of 13.
That's absolutely correct. So 12 and under, no ET tubes. It's going to be your supraglottic. That's going to be your LMAs. No intubations under 12 and younger.
Okay, everybody. Well, thanks for listening. Hopefully you got some general takeaways of, pediatric trauma, how they're a little bit different than adults. They got bigger heads, they got more flexible bones, and be suspicious of underlying injuries. Any other takeaways that you have, Kevin?
I think we're good, Andrew. I think we covered a lot of it, and hopefully this helps everybody treat those pediatric patients.
Perfect. All right. Thanks for listening, guys. Talk to you on the next episode.